Front of the knee pain below your kneecap, worse when your knee is straight or locked out, hurts more downhill, standing or after runs. You might not just have runner's knee, it could be Hoffa's fat pad irritation or Hoffa's fat pad impingement. And no, you don't need to jump to surgery in most cases. I've personally actually dealt with this and rehabbed with it on a regular basis. Today, I'm going to show you exactly how runners fix it without having to just rest it forever or, jump to surgery or injection. I'm Dr. Peralta, physical therapist, a run coach, and I've worked with injured runners over the past 10 years now. And I've seen this, get misdiagnosed as just a generic knee pain in runners, or that they just have to stop running altogether. It's running's fault that you're having this knee pain. And I also want to share with you guys that MRI findings are not always the root cause, right? You're typically just seeing the symptom, like this irritated knee is just a symptom of something else that's going on. About 50% of pain-free people show abnormalities on MRI, such as degenerative changes, meniscus tear, etc. I'm not saying that can't be, the painful structure, right? That the thing that's painful, but doesn't mean that, you always have to, again, jump to surgery. A lot of times there's something that's causing that tissue to be irritated. And if you want access to this Google Doc, check out my free online running school group, link in the description. So let's talk about what Hoffa's fat pad actually is. So it's a soft tissue under the kneecap, right behind the patella, highly sensitive vascular structure that's supposed to act like a shock absorber in a normal, healthy, functioning knee. But then it could get irritated with repeated compression, especially with full knee extension, overloading, downhill running. It's more of an irritation problem than some tissue that's being there. Because fat pad is just like fat pad tissue, but then it can get caught, it can get impinged or inflamed underneath the patellar tendon, underneath the kneecap. So you feel it in the front of the knee, typically. You typically have to go to a doctor to get diagnosed and all that. You may show up on the MRI of it's like Hoffa fat pad impingement or irritation. So symptoms that runners should recognize, right? Again, pain below the kneecap, sharp, pinchy, worse when the knee is fully straight, tender around the patellar tendon, and pain standing with the knees locked. And I talked about downhill running. And it can actually feel a little better when the knee's slightly bent. So why runners actually develop it? It's not just weak quads. It's a load management issue, right? I've had so many runners are either ramping up, they're maybe training for a marathon, half marathon, or they just run too many days of the week, running 5, 6, 7 days a week, thinking I have to run more. Or they, again, have a sudden spike in miles. I heard I have to run 40 miles a week, 60 miles a week for a marathon. And then they, cause this irritation or overload to the joint, or to the fat pad in this case. Or maybe they started getting overzealous with hill workouts, doing the downhill running. And downhill has a lot of eccentric loading on the knee, so a lot of eccentric that's going to put a lot of force through the joint or the knee joint or the tissues around it. Overstriding, right? So when your foot is overstriding, the extended knee at initial contact, when the foot's hitting the ground with running, that can put excessive stress on the knee as well. And then just generally hyperextending your knees during your daily life. Maybe you work a job where you're standing and you just kind of lock out your knees as you're standing. That could be hyperextending the knee, adding compression load to just standing still for like hours on end. That could be a big issue as well. Or you tend to be more quad dominant, use more of your quads, versus your hamstrings or your glutes. That could be a big issue. And then also poor control of the femur or the hip and the thigh muscle, which when that is weak or causes issues upstream, that could affect the knee joint because the knee is, again, the middleman and the tissues around the knee could be irritated. And it's also usually classic in runners who think they have that mentality, I'm going to keep pushing through the pain. Pain is normal. Push through the irritation. And then you keep pushing, and it prolongs or delays the healing process. So now something that could have been, rehabbed in just 6 to 8 weeks now takes you 6 months to rehab or even more, which could be very frustrating, especially if you love to run. But sometimes you have to put on the brakes, pump the brakes, little buddy, is what I like to say. So lifestyle mistake most runners make. Standing with the knees locked out all day, right? I talked about this. So if you have to stand or be in one position for too long, change positions or have like a soft bend in the knees. Also be mindful of what your knee's doing when you're running, post-running. So after a run or a workout, how are you resting afterwards? Are you resting with the knee locked out? Make sure you give it a slight knee bend that might be more comfortable. So these small habits can actually lead to a big symptom reduction. A lot of times people don't recognize how impactful posture or lifestyle habits can be on the knee. But I also want to talk about some lesser known contributors. So previous trauma or fall. So sometimes people they think it's running, but maybe it was a fall. I actually had this exact problem. I had Hoffa's fat pad impingement. I even have it on my MRI record when I went to the doctor. And yes, running downhill aggravated, but it really got triggered from I was actually doing pull-ups and I lost my grip on the pull-up bar, and then I landed on my knees. And so I ended up getting, both knees irritated, but it was actually my right knee that had the worst pain. You just got to put more pressure on there. And it took months to rehab, even though I'm a physical therapist. It was just compressed. And I also had the stubborn runner mentality. I was like, I got the marathon. I got to train. I ain't going to stop running. So it just prolonged the healing. And that was my own stubbornness. But I get share this because a lot of runners are also stubborn and they keep pushing through the pain. And then it's like, okay, if you just took a temporary break from running, you could allow the joint to heal. But I understand it's tough when you have a race that you signed up for, especially if you have a marathon. I understand it's tough. But also you have to address the bigger picture if you have multiple pains, right? If it's not just the knee, if let's say you have pain in the thigh, the hip, the back, heck, you may even have shoulder pain and arm pain. Like if you have pain all over, you may have systemic inflammation. You may have like rheumatoid arthritis or some autoimmune condition. You may have to consult with a specialist to get like special blood work to check that out. I'm going to share my story because I actually also have gluten intolerance, right? It wasn't the primary cause of the pain. And for probably people like scratching their head, what are you talking about? Gluten intolerance. So for me, the gluten intolerance, when I have too much bread or wheat products, I actually get joint pain. My joints actually inflame. So it actually causes more inflammation in my body. So just by simply getting rid of the gluten, my pain decreased. Now, it wasn't the only cause, but it was a big contributor to my pain. I've actually seen something similar with my athletes that, again, not everyone, but a small percentage of them, when they like change their diet, remove foods that are causing inflammation, they actually notice a big reduction in the pain. They still got to do exercise, got to do rehab, but the diet can play a significant role for a certain type of people. Even foods like dairy and nightshades as well. Again, less common, but possible. Just want to share that with you guys as well. And then also the pain in the knee can actually be referred from the hip or the back, especially if you're feeling like, again, pain down the thigh, pain in your buttock, pain in your calf or your ankle. There might not just be knee pain. You actually might also be dealing with hip or back pain that needs to be addressed as well. But if you're not sure, you should be working with a specialist, someone who understands how to look at the whole body, take this biomechanical approach, especially someone who understands how to work with runners, kind of someone like myself, right, to help you out. So rehab principles: avoid aggressive end range knee lockout, right? Don't lock out the knee. Don't do hyperextension of the knee. Train in the pain-free or tolerable range of motion, right? The pain-free zone. Load management, greater than doing random exercises, right? You also typically want to strengthen the glutes, the posterior chain, because oftentimes your anterior knee pain, that pain in the front of your knee, is usually due to weakness in the back of your knee, right? The hamstring, the glute, even the calf. And make sure you're able to strengthen without getting a flare-up in your symptoms. If next day your pain is worse, you probably overdid it with the exercise. Yes, you can overdo it with rehab exercises, so you may have to scale back the rehab exercise. And you may have to temporarily modify your runs. You maybe have to switch to a run-walk, but even if run-walk is too irritating to your knee, you may have to just shut it down for a month, right? Like you may actually have to take hit the pause button on running if you even run-walk at like an easy pace flares up your knee. So you may have to take a break. I know runners hate to hear this, but sometimes you have to take a break from running. So pain traffic light guide, right? Green light, 0 to 3. That's mild pain. You get the green light, you can still run it. I still recommend reducing the volume, the mileage, or the speed, right? Maybe reducing at 30%, 50%, right? So you're going at an easy pace. And I still recommend doing a run-walk method if possible. But again, you can also do continuous running if the pain is minimal and it doesn't get worse after you run workouts. Now, if the pain starts creeping up, maybe to 4 to 6 out of 10 pain, a yellow light, modify the load. This is truly where you should actually decrease it to 50%. I know I mentioned it for the green light because I like to be conservative with my runners, but this is at the yellow light. You should definitely reduce the load. If having a flare-up, this is where, let's say you were running 40 miles a week, decrease it to 20 miles a week, right? A 50% reduction in load just to give your body enough time to heal. I know that might be frustrating to hear when you're training for a marathon, but listen to this. It's better to be healthy. And you could oftentimes keep your cardio fitness cross-training, hop on the bike, do rowing, swimming, walking, brisk walking. And if you're getting a red light, severe pain, seven or more, on a 0 to 10 scale, like that severe pain, then knees really swelling up on you, it's causing you limp, both your knees hurt, and you're limping in both of them. Obviously, stop. You may have, this is the point where if you're getting severe pain with running, stop running at least for a month to allow it to calm back down. Now, sometimes you don't have to do a whole month. Maybe you could do 2 weeks. It will calm back down and you could typically go back. But if every time you try to pick running up or even run walking and you get the severe pain, consider taking a longer break, a month or even 2 months, to really focus on the rehab aspect. But if you're able to tolerate it, then yes, obviously you could do if it's in the green light zone or yellow light zone, you could continue running there. So what are the exercise things we want to focus on? Glutes, big fan of strengthening the glute or the posterior chain. All right, so we want to make sure these muscles are nice and strong. It's going to improve control at the knee, reduce the stress at the knee, typically slow controlled reps. You can actually do this daily because it's like muscle activation, but if you're very busy, even 3 times a week is going to give you benefit, right? So even if you just trained your glutes or posterior chain 3 times a week or 3 days out of the week, still beneficial. So glute bridges, prone hip extension, hip abduction, deadlifts, right? You could progress 2-legged, single leg deadlift, heavier weights. In the beginning, you might start with body weight, right? You're dealing with pain, but as you get more advanced, the exercise is getting easier. You go from 2-leg to single leg. Here's a single leg glute bridge. You could do the hip thruster. You could add a weight to that. Same thing with the deadlift. Even with the hip abduction, you put ankle weight. You could put heavy resistance bands. Both strong hips, less stress on the knee. Isometrics. So when your knee's irritated, you can still strengthen your knee, but you do it without fully locking out the knee. You could do things like isometrics. Here you could do like a wall sit hold. If it's too difficult, you could just simply squat, sit higher up. So instead of squatting, she's in the model here in the picture, she's at 90 degrees, but you can go to like 60 degrees, 45-degree knee bend. Essentially, you're doing a high squat. You're just back on the wall at a higher angle. Then as you get stronger, you go deeper down in the deeper angle, like 90 degree or even lower. And then you could also do a seated knee extension isometric, 30-second, 45-second, 5 sets. Strengthen the quad there. So you take your full side. If both of them are painful, then obviously you do both of them. But anyhow, you take the side you want to work on. It's going to be behind the other leg. And then you can see my mouse cursor. That side is going to push against the opposite leg. And you hold it for the 30 seconds. And typically, isometrics actually help decrease the pain. So you get like a hypoalgesic effect on the joint or in the knee. Mobilities. You also want to work on mobility. There's going to be different dosage recommendations, but as a general rule, I like to do longer holds. Now, if it's too painful or uncomfortable, you could do shorter hold. You could do 30-second hold. You could do 10-second hold. But regardless, you want to accumulate at least 2 minutes. But I actually like going up to 3 or even 5 minutes, especially if vertically tight. Let's say you have tight quads or tight calves. Here I got a calf stretch or hip flexor stretch. Again, if it's painful, you could do the shorter hold, but stretch your tight areas, do it daily, thinking like brushing your teeth. You want to brush your teeth daily, do mobility daily, and focus on your tight areas. Again, if you're limited on time, a minute hold is fine, but really try to go up to the 3 minutes, 5 minutes. And obviously work on your tight areas because the ones that are pictured here might not be applicable to you. So pick the areas that are tight or restricted on you. Squats. So squats is also very important to do to help you restore weight, load tolerance in the knee. Avoid going into a full knee extension or full lockout. You could progress double leg, single leg loaded. Right. So you can even regress a squat. You could actually do an assisted squat here. The model in the picture is holding onto a door frame, a doorknob, and using a doorknob to go squat onto a chair squat or essentially a box squat assisted. Then you can let go of the door, do just standard chair or box squats, and you can even add weights to the box squat, even do a free standing squat, like a traditional like goblet squat there. You can go to barbell squat. So there's so many different ways to start progressing it. As long as your knee, again, is that green light, yellow light's not getting worse, you're able to progress, especially if it's a green light. If it's green light, then you can start progressing, adding more weight, and then even going from a 2-legged squat to a single leg squat. And then eventually, after like 6 to 8 weeks of strengthening, that your knees feeling healthy and robust, you start doing jumping. Jumping is also very important. You can do jump squats, jump onto a box, etc. And then with this type of training, eventually you want to strengthen your knee 2-3 times a week, and then jump training also like 2 times a week. So you may actually be going to the gym or working out from home, but essentially you're at least training at least 3 times a week, especially if you're trying to rehab the knee and build it back up. And then as you start getting healthier, you go down to like twice a week. So modifications, right? So you usually want to reduce downhill running because downhill running is going to be one of the things that worsens or aggravates your knee. So take a temporary break from downhill running. Avoid sprinting in the early phases. You might want to increase your cadence to help you reduce overstriding. So let's say your cadence steps per minute is at 150 steps per minute. Try to get to like maybe 160 steps per minute or 170 or even 180, depending where your starting point is. Don't make a big jump, right? Don't say, I have to go to 180. No, if you're at 150, maybe make a 5% jump or a 10% jump, right? Don't go, make a giant jump because that could cause issues as well. Reduce your frequency, not just your pace, right? So training frequency, instead of training every day of the week, if that's what you're doing for running, consider going from 6 runs a week to just 3 runs a week. I tell people it's better to cut out the junk miles, especially if the mileage is causing you to get more pain. You could always build it back later, but let's go down to like maybe just 3 runs a week, right? And then cross training, bike, rowing, swimming. And especially have mandatory recovery days, especially if you're, going over 35 years old, over 40 years old and above. And return to run. So when are you able to return back to normal running? Pain's minimal, less than 2 out of 10. No swelling. You have like full range of motion in the knee. Able to walk comfortably 30 minutes pain-free. You can do your strength exercise like the squats and the deadlifts and the lunges, pretty much minimal pain or pain-free. You could pass the jump test, the hop testing, and there's side-to-side symmetry when you compare, let's say your right to left side in terms of the distance you cover, the height. There's different types of hop testing you could do. Typically, you do this when you're working with a physical therapist. So if you're already working with one, hey, make sure your physical therapist is testing these things with you. And then once you're able to pass out at least like 80% symmetry or more with the strength and the hop testing, and then you could start going a run-walk program, like doing 1 minute run, 2 minute. Do that for 15 to 20 minutes. Do it 2 to 3 times a week. If that's very easy, sure, you could go up to 30 minutes or even 45 minutes, but start small and then build your way up. And then gradually progress. I got here 4 to 8 weeks, but sometimes it may take you 6 to 8 weeks. And if it's a really persistent case, sometimes people have like a chronic knee pain or chronic fat pad impingement. It actually may take even 6 months. Again, it may vary depending on the chronicity. Most people do respond in 6 to 8 weeks. Some people even respond in 4 weeks, especially if you're doing a smart training plan. So red flags, when to get help. If the pain if you're doing physical therapy, but it's not getting any better, it's been 4 weeks, you're clearly still in severe pain, you still have sharp pain even when you're walking, or if let's say you're still trying to run, you're still having severe pain, worsening despite rest, maybe you've been somewhere else and they just told you just have runner's knee, but you think something else might be wrong, obviously go to your doctor, go to the orthopedist, get checked out. If you tried the physical therapy, it hasn't gotten better despite them doing, some of these load management exercises, right? Progressive trying to strengthen your knee, still not getting better. Consider getting a second opinion before getting surgery. But hey, maybe you want to do cortisone injection or hyaluronic acid injection, right? I'm not totally against injections, right? Especially if you already tried PT and the PT didn't work for you, definitely could go the injection route. But then even after the injection, you still want to resume PT as well. But you may have to get a different PT because if you've been working with one PT and you're not getting results, consider working with a different PT. So in closing, Hoffa's fat pad pain or impingement is typically due to an issue with load and mechanics, either biomechanics or your lifestyle. It's not just about just stretching or just resting altogether. Smart training can lead to being pain-free for longevity and be able to run well into your 50s, 60s, and beyond. All right. And, if you're like training for a marathon or you're increasing mileage, it's especially important, right? If you're trying to build up to 40 miles per week, 60 miles per week, understand, hey, look at your training. Maybe there's a smarter way to train. If you want the exact rehab roadmap I use with my runners to help them run pain-free, I currently have a few spots open to work with me one-to-one to run pain-free. So if you're curious, there's a link to apply in the description. First come, first serve.